Good morning, everyone, and welcome to the second session of Hall A, which is Ocular Pathology, Oncology, Tumors, Orbit, and Oculoplasty. This is a great pleasure to welcome the chair and my colleague moderator. So I welcome Professor Neelam Pushkar ma'am. She is Professor of Ocular Oncology, Orbit, Oculoplasty at Dr. RP Center of Ophthalmic Sciences, AIMS, New Delhi. And with me, the session will be moderated by Dr. Shachi Srivastava. She is from ESIC Medical College, Faridabad. Without further ado, I hand over the mic to our Honorable Chair to start the session.
Good morning, everyone. Warm welcome to all of you. So today we have interesting papers and in the field of ocular pathology, oncology, plasty, orbit. So I think without further delay, we can start the presentations. So I hope the presenters are aware of the duration of their presentation, which is 4 minutes. And all right, so we start with the first presenter, Dr. Anita Mani. Is she here? Okay. So she is presenting her paper on orbital myositis in young. Looks a bit incomplete. Young patients.
Good morning to all. Today I'll present an interesting case of orbital myositis in a young individual. My patient was a 23 years old male. He initially presented with a gradually progressive painful swelling of the left eyelid with chemosis of 15 days duration. The swelling decreased once he was managed with oral antibiotics and topical eye drops for 5 days. Then subsequently he reported with a complaint of double vision in the straight gaze, for which he reported to the hospital. So this was his initial presentation. When he presented with diplopia, his visual acuity was 6/6 both eyes, near vision N6 both eyes. The extraocular movements were full, free, and painless in all directions of gaze. So this is a picture showing extraocular movements. There was no restriction or any abnormal movement seen. However, the diplopia charting revealed diplopia in all gazes except the straight gaze. And diplopia increases in the superior gaze. So we investigated him thoroughly for the same. Systemic investigations and infectious disease panel did not reveal any abnormality. Thyroid function tests were within normal limits. Serum ACE was within normal limits, so it ruled out sarcoidosis. The autoimmune workup, complete autoimmune workup was also done. ANA, P-ANCA, C-ANCA, anti-RO-LA were negative. This MRI was done subsequently, which showed an enlarged bulky superior rectus measuring around 3.5 mm. So a provisional diagnosis of idiopathic orbital inflammatory disease was made since all investigations were negative and presenting as orbital myositis. Since the superior rectus was bulky and impinging on the optic nerve, he was given a course of IV methylprednisolone for 3 days, followed by oral prednisolone in tapering doses. He showed a rapid response and there was improvement in diplopia and resolution over a period of 1 week. Repeat MRI at 2 weeks showed a decrease in edema around the extraocular muscles and normal optic nerves. Coming to the discussion, orbital myositis is a spectrum of idiopathic orbital inflammatory disease, earlier known as orbital pseudotumor. Generally presents in the 3rd to 4th decade, common in females, and recurrence is observed. One or more extraocular muscles are involved. Order of involvement medial, followed by lateral rectus, then superior and inferior, followed by obliques and levator. The muscle inflammation is often, but not always, there is involvement of the anterior tendon. It presents as diplopia exacerbated on ocular movement. There may be chemosis, conjunctival injection, and proptosis. The secondary causes include giant cell arteritis, SLE, granulomatosis with polyangiitis, sarcoidosis, Crohn's disease, malignancies, and infectious causes. All the investigations were negative in this patient. Herpes zoster, Lyme's disease, cysticercosis, and upper respiratory tractions infections are other infectious causes. There is a dramatic response to oral steroids. Relapse may be seen on tapering of steroids months or years after the episode. Immunosuppressants and biologicals may be used in steroid unresponsive and recalcitrant cases, low-dose orbital irradiation in unresponsive cases. This is a unique case since it was a young individual, a male, and no secondary cause was detected. Thank you.
Thank you, Dr. Anita. I think it's a isolated myositis is as such a known entity. Yes. And we know idiopathic we label after excluding everything. So generally when there is only one muscle involved, we think of cysticercosis. Yes. So did you specifically look for cysticercosis cyst in the muscle? Sometimes we can miss on the MRI and ultrasound helps.
Right, ma'am. We didn't specifically look on ultrasound was not specifically done, but MRI was done subsequently where the inflammation resolved. But we didn't specifically
no
look
cyst, or
no
you
cysts
did not
were
look
detected, ma'am.
Okay. All right. So the response was complete?
Response was complete. He had, within 2 to 3 days, his main complaint was diplopia. That resolved in 2 to 3 days. And within a week, he showed complete improvement.
All right. So what was unique about this case, as you said that because
it was
it's a known thing?
The presentation, generally we see in the older age groups, this was a young individual with no other comorbidities.
No, even in young individuals, you you come across, idiopathic orbital inflammatory disease where there is only one muscle involvement. Muscle. And other thing, you said that extraocular movements were normal and there was diplopia, so that is something which is contradictory. So did you go back and see whether there was any, extraocular motility problem also? After doing the diplopia charting, did you go back and see that like maybe it was missed?
Restriction specifically maybe could not be, no gross restriction was made out on the extraocular movements.
All right. Any other question?
Are you still following up the patient? I mean, for
no,
any relapse or something? I mean, how much time it has passed for the remission to?
Actually, being in armed forces, transferable job, sir. This was in my previous institute. So after that, I could not follow up this.
And the other thing was, like, I was also noting that the extraocular movements you mentioned, they were fine, but in diplopia, the patient had diplopia, so that was something which was kind of.
So that was actually we could not. That's why we went in for an MRI and subsequent investigations.
Okay, maybe in the follow-up, if the patient relapse or something, we can go for the orbital ultrasound to rule out a single muscle cysticercosis.
Right, sir. I'll try and follow up.
Thank you.
Thank you, Chairperson.
Thank you. Now I'll invite our second speaker, Dr. Shalini Kumari. She'll be presenting benign eyelid lesions and its histopathological picture, a case series.
Good morning. My topic is benign eyelid lesions and its histopathological picture, a case series. A wide spectrum of lesions can arise from eyelid as various skin appendages are present in it. Both benign and malignant tumors can originate from any of eyelid layers. Coming to materials and method, mine is a prospective case series. First 9 patients referred to the author with unilateral eyelid lesion in a tertiary referral setting in the month of April 2024 were taken up for the study. Main outcome measures are clinical features, histopathological pictures, and response to surgical intervention. I think the presentation which I uploaded is a different one. Please change it. Lot of things, please. I uploaded the presentation in the morning hours. Please change it.
I think she can start again.
I think we can stop the timer and you can start again.
Sir,
yeah.
Morning hours, yes.
I now call upon our third speaker, Dr. Sonali V. Kumar, who is presenting on choroidal melanoma in a young population is on the rise, experience from a tertiary care facility.
Very good morning to all of you. The paper which I am going to present today is choroidal
Please
melanoma
reset the timer.
in young population is on the rise. The incidence of choroidal melanoma worldwide is 5 per million, and in Asian population is 0.5 to 0.8.
Sorry,
And
we cannot see the slides. There is some.
slide is not the
Yeah. और timer भी set कर दीजिए, please. Reset the timer for the speaker. Now you can start, ma'am.
okay. So incidence of choroidal melanoma worldwide is 5 per million, and in Asian population is 0.5 to 0.8. It is considered to be a disease of elderly age group, and common risk factors are advanced age, fair skin, family history of uveal melanoma, and exposure to UV light. It's not moving. Most of the time, it is not diagnosed on time, as patients seek consultation when they develop sudden loss of vision. And further, the rate of diagnosis of this entity in young population is dismal. Incidence of choroidal melanoma is less common in the Indian population, and in younger population it is rarely seen as per various published studies. There are very few studies which have commented on occurrence of choroidal melanoma in young Asian population. Hence, this study was undertaken to raise awareness that this entity can occur in younger age group. So it was done at Army Hospital Research and Referral. It was a prospective observational study. It was done for 5 years, and patients who were less than 30 years and diagnosed with choroidal melanoma were included. The consent was obtained in all cases. 12 patients were seen during the study period. Detailed history was taken. Investigations like FFA, OCT, B-scan, and MRI orbit with contrast were done. PET scan was done to rule out systemic metastasis, and details of the lesion were noted. At our institute, we formulated our treatment plan based on the basal diameter of the tumor and thickness. And enucleation we advise when the basal diameter is more than 18 and thickness more than 10 mm in size. All patients were followed up for 2 years. So mean age of the population was 23 years. There were 2 male and 10 female patients. All had unilateral presentation. Right eye was involved in 5 and left eye in 7. And there was no family history of choroidal melanoma. Common clinical presentation was sudden loss of vision and elevated lesion with exudative RD. There was no sign of ocular and systemic association. Mean basal diameter of the tumor was 21 and the thickness was around 11. Common tumor configuration was dome-shaped lesion, and pigmented tumor was found in 11 patients. SRF was noted in 12 patients. All had advanced stage of choroidal melanoma, and histology showed epithelioid type of melanoma in maximum number of enucleated eyeball specimen. So primary treatment modality was enucleation in these cases, as the basal diameter was more than 18 and thickness was more than 10 mm in all cases. Implant exposure was seen in 2 patients. There was no sign of recurrence. None of the patient was found to have systemic metastasis at the time of presentation, and no mortality was reported at the end of 2-year follow-up. So these are the common B-scan and the MRI orbit were the common imaging modalities. And these are the few cases of choroidal melanoma who were treated at our center. So our study has shown that choroidal melanoma in young population has increased as the mean age of the presentation was 23. So this was not in conformity with Shield et al. However, Biswas et al., they reported that Asian patients present with choroidal melanoma at a younger age group. The disease was found more common among females in our study, and this was in conformity with Singh and Shield et al. However, Conte et al. Reported like choroidal melanoma occurred more in men compared to females. The common symptom was sudden loss of vision, and the common sign was retinal mass with RD, and this was in concordance with Rupert et al. In our case, in our study population, all the tumors were large size. So this was in discordance with Shield et al. As they reported smaller size of the tumor in younger population. None of the patients in our study group were found to have any risk factors. So this was not in conformity with Singh, Shield et al. As they reported ocular melanocytosis was a common association. Histopathological examination showed epithelioid type of melanoma in our study population. This was in contrast to Rupert and Singh et al. As they reported mixed type of choroidal melanoma as the commonest type. So common treatment modality was again enucleation with implant, and this was in discordance with Duper et al. And Singh, as they offered various treatment modality to their cases in their study. So this study is the first study from Indian subcontinent which has exclusively commented on choroidal melanoma in young population. So main limitation was a small sample size and short follow-up period. And thirdly, the observation was made at a single center. Hence, the findings may not be the too representative of the population. To conclude, choroidal melanoma should not be considered as a disease of elderly people. The prognosis is abysmal if the lesion attains a huge size, and a high index of clinical suspicion is required to diagnose this entity in younger population and to achieve better outcomes in this age group. These are my references. Thank you.
Thank you, Dr. Sonali. It was a nice study and with good discussion. I just want to know, in literature, is there any known differences between the younger versus the older population melanoma presentation,
there are few studies.
histopathologically or clinically? Is there any difference?
There are few studies. They have commented like in younger population, the size of the tumor is small, and the prognosis is better compared to the elderly population.
Probably because they present early.
Maybe, but most of the time it is not considered. Like whenever we are seeing in our OPD also, like this disease is never considered. We always presume it will happen in the elderly age group. So
what was the vision like? Because younger population generally they are
Yeah,
aware that the vision
though
is
it's
dropping,
smaller,
and
but
they will not
they
say.
don't report, because if it is doesn't involve their macula and all those, so they don't notice that there is any drop in the vision. When they develop, like all these cases which we have seen, all had advanced stage of choroidal melanoma.
What was the vision like at presentation?
It was hand movement close to face, because there
And
was a
the font size was so small. I guess you are not presbyopic, Abhina, isliye that's why you don't realize that it has to be.
So because that's why we
even
offered
from
initially-
distance we couldn't read anything.
No, ma'am is asking about the presentation.
About the
font,
presentation,
not the
font
size of the tumor.
not the size of the tumor. We couldn't, we hardly could see anything, So font size should be at least, 24, 20, so that at least people can read. I guess it was very small,
And
Can you derive or can you think of any risk factor which might be associated with increased incidence of choroidal melanoma in young population?
like if there is a ocular melanocytosis or systemic any problem, these are the common risk factors which are associated with.
Any
For-
systemic association in any of your patient which you thought you should rule out?
Like dysplastic syndrome, nevus dysplastic syndrome. So this is the common risk factors which are associated with choroidal melanoma.
thank you, Dr.
And what
Sanal.
about the PET finding? Did you discuss? Sorry, I missed that.
We did PET scan in all the case. We didn't find any sign of systemic metastasis.
Okay.
Last thing, just to finish it off, you have just skipped the slides ki, like more than in 18 mm basal diameter, you did the enucleation. And what was the second, like it must be in concordance with the COM study or something, like in the small, medium, what do you
as
do?
per their study, like if the size of the tumor is less than
No, in your case, what did you, what is your protocol?
like in our cases, like in this study, all had advanced stage of choroidal melanoma, so we
Okay.
couldn't offer globe salvage treatment.
In younger patients, I mean, although you have already mentioned the vision was very poor at the time of presentation, have you considered GKT or any globe salvage therapy in these younger individuals? Or just
if
straight
they
away
report,
enucleation?
If they report early or tumor is of smaller size, like we have other facilities also.
But
Like
in large tumor also, we have two options. Like we can go, if the patient wants, then we can go for globe
no,
salvage GKT.
if the size of the tumor is more than 18, and then the risk of systemic metastasis is very high. So in that case, we should not take any chance, because they are younger age group. So we can increase the longevity of this patient by enucleating the eyeball instead of
In GKT, there is a
exposing
22% chance of the
in spite
systemic
of offering their
metastasis.
globe salvage,
Okay.
because it's not going to help them.
Okay, thank you. Now, Dr. Shalini Kumari, I mean, if the presentation is ready, the second speaker.
Good morning. My topic is benign eyelid lesions and its histopathological picture, a case series. A wide spectrum of lesions can arise from eyelid lesion as various skin appendages are present in it. Both benign and malignant tumors can originate from any of these eyelid layers. Although it is known that majority of eyelid lesions are benign, yet ideally all clinically benign appearing eyelid lesions should undergo histopathological analysis to rule out malignancy. Thorough knowledge of clinical features and subsequent confirmation with HP aids in early detection of tumors, more so in masquerade syndromes, and also in reinforcing an ophthalmologist clinical diagnostic opinion. The purpose of this case series was to evaluate the clinical features, HP picture, and treatment of benign eyelid lesions in a tertiary referral setting. The design was prospective case series. First 9 patients referred to the author with unilateral eyelid lesion in the month of 2024 April was taken up. Main outcome measures I have already mentioned. Coming to results part, benign eyelid lesion in our case series were epidermal inclusion cyst, giant conjunctival inclusion cyst, epidermoid cyst, dermoid cyst, intradermal nevus, dermal nevus, apocrine hydrocystoma, capillary hemangioma, and lobular capillary hemangioma. So my first case was epidermal inclusion cyst. It usually presents as a smooth, round or oval domes epidermoid. In our case, it was excised, followed by eyelid reconstruction by Tengel's semicircular flap method. The second case was a giant conjunctival inclusion cyst in a young 4-year-old child, which is an uncommon adnexal lesion in children. It was causing mechanical ptosis. It was excised entirely by a modified noose technique. Our third case was an epidermoid cyst. Epidermoid or dermoid cyst is the most common cystic orbital lesion seen in children. It's a choriostoma. In toto excision of cyst using lead crease incision approach was used in our case. Third case was a dermoid cyst. Dermoid cyst clinically appears as an eyelid tumor, has contiguous extension of an orbital lesion. Again, in this case, in toto excision was done using lead crease incision approach. Our fifth case was an intradermal nevus. A type of intradermal nevus, it presents as a homogeneous globular pattern. The intradermal nevus, most benign type of nevus, is sometimes known to transform to melanoma, very rarely. So this acquired type of nevus again underwent save excision with no recurrence so far. Our sixth case was a dermal nevus. Nevus of eyelid is characterized as a common benign melanocytic lesion. In our case, again it underwent save excision with no recurrence so far. Our seventh case is a case of apocrine hydrocystoma. It's a retention cyst. It is located at eyelid margin in adults. A blocked excretory duct of Gauss gland is its origin. Marsupialization of cyst was done. Our eighth case was actually a capillary hemangioma, which is the most common benign vascular tumor of eyelid in childhood. It's a congenital hematomous lesion. Our case was a superficial variant localized to epidermis and dermis. And since it was amenable to excision with meticulous hemostasis, the lesion was transected utilizing electrocautery. Our ninth case was a lobular capillary hemangioma, which is a common vascular lesion of skin and mucous membrane in infancy and childhood. There were history of episodic bleedings in our case. It was treated with tangential excision and cautery. So coming to discussion part, in our case series, all 9 cases were of benign origin. Nevus 2 in number was the most common benign lesion in our series. Again, the histopathological diagnosis of 8 lesions were consistent with their respective clinical diagnosis, while 1 lesion, epidermal inclusion cyst, was misdiagnosed by us. While a large study conducted by Constant et al. Reveals 13 cases to be malignant and 3 to be pre-malignant on HP examination, out of pre-thought total 692 benign lesions. In our cases, all cases underwent surgical intervention. No cases showed any recurrence during follow-up. So coming to conclusion part, thorough knowledge of clinical features of all eyelid lesions and subsequent confirmation with HP examination of excised tissue is a must, as it is not possible to obtain 100% accuracy in diagnosing eyelid lesions on clinical grounds only. These are my first 5 differences. Thank you.
Thank you, Dr. Shalini. It was a nice presentation, complete set of pictures. Each patient you have shown very nicely. Just one question. In case number 1 and 2, you said that you did tensils, and in the case 2, you said you did Hughes. So I was wondering, in benign lesion, generally we don't do full thickness, removal of the eyelid and go ahead with this kind of thing. So what was your case, why it was done?
Ma'am, in the first case, since I have been attending and discussing it with my colleagues and seniors, so they say through lead cage incision, the epidermal inclusion cyst, it can be taken out. But it was my first case. First, I reconstructed it. It was actually went into re-surgery, did with the direct approach, and since it was more than half, almost half, that was a misdiagnosed one. So ultimately, I have to do the re-surgery with Tengel's flap. I know that it can be done through lead increase.
Yeah, only the cyst removal is
Yes,
required. And similarly, in the second case, you just have to go ahead with the cyst removal. You don't have to raise any flap or do any
No, it was a noose technique. Just reversed it. It was a huge one, and
But generally, that is also not required. So I was wondering, because generally these cysts, you can just give a cut in the conjunctiva or skin, and you can just take it out, and rest of the tissues you have to leave as it is. So augmentation generally is not required until unless you are taking out with the conjunctiva for some reason. Then you might have to put a graft or a flap over there.
Underside the conjunctiva only I dissected. I thought that I'll end up puncturing it. So what I did was just applied a noose and then pulled it. I have a video also, but of course I can't show it. And then took it out so that it's taken out in toto and there is no recurrence.
That was fine, but why Hughes procedure? That is my question.
I had I was going
Some
through the
defect was
literature.
there,
They said that cysts can
okay.
be taken out with the noose technique better without that. That was the only purpose, nothing else.
Okay, thank you. Any question? Okay, thanks. You can invite this in.
Now I'll invite our next speaker, Dr. Anubha AJ. She'll be presenting recurrent external angular dermoid cyst.
Good morning, everyone. Here is a case report on recurrent orbital external angular dermoid cyst. A 28-year-old lady visited OPD with chief complaints of swelling over left upper eyelid since 6 years. Swelling was insidious in onset. Initially the size of a peanut, has steadily progressed to the current size of grape over the last 6 years with no associated pain or discharge. There was no history of trauma, no associated aggravating or relieving factors. There was history of similar complaints 20 years ago at the same site for which she underwent surgery. No other significant history could be elicited. On examination, 1.5 into 1 centimeter, smooth, firm, round, non-tender with clear margins, mobile under the skin swelling could be palpated in the superotemporal part of left orbit. And a previous surgical scar of about 2 centimeter was also seen. Best corrected visual acuity in both eyes was 6/6 and both eye anterior and posterior segment evaluation was normal. MRI revealed a hyperintense cystic lesion along the subcutaneous plane of the lateral margins of the left orbit, measuring 1.4 into 1 to 1.2 centimeter, likely angular dermoid cyst. After necessary investigations, patient was planned for dermoid excision. Intraoperatively, external lateral subbrow incision was given over the mass, and 2 into 1.5 into 1 centimeter cyst was excised in toto, and rest of the surgery was uneventful. After tumor excision, postoperatively, patient was given oral and topical antibiotics with analgesics for 5 days. Postoperative results were satisfactory with a well-concealed heel scar. Suture removal was done after 10 days. Excised tissue was sent for histopathology, which showed stratified squamous epithelial lining with dermal appendages as contents, confirming our diagnosis of dermoid cyst. And then patient was followed up to monitor any complication or recurrence. Coming to the discussion part, orbital dermoid cysts are a type of choriostomas most frequently encountered in children, can be seen in adults as well. They occur due to displacement of ectoderm to a subcutaneous location along embryonic lines of closure. Histopathology shows stratified squamous lining containing dermal appendages like sweat glands, sebaceous glands, and hair follicles. Dermoids can be superficial or deep depending on its relation to the orbital septum. Superficial dermoid cysts present as a painless nodule, mostly in infants and children, frequently in the superotemporal part with features which was seen in the case. Deep dermoid cysts are common in adolescents and adults, present as gradually progressing proptosis or acute inflamed orbit following its rupture or infection. Posterior margins of cyst could be indistinct with associated bony defect or an extension into intracranial and infratemporal fossa. Management of both is by surgical excision in toto without rupturing the wall, as keratin leakage can cause severe granulomatous inflammation or recurrence. So in conclusion, orbital dermoid cysts are one of the most common benign tumors of the orbit. Examination, imaging, and histopathology features help in differentiating from other related lesions like epidermoid cyst and dermolipoma. Superficial and dermoid cysts have different presentation at different age, progression, and associated complications. And surgical excision is recommended to avoid complications like rupture, cutaneous fistula, progression of tumor growth, and bone erosions. Thank you.
Thank you, Dr. Ganjana. How you pronounce your name?
Anubha.
Anubha. Acha. Which one? Acha, co-author, Anubha. All right. So I was just wondering that your case was a recurrent, this thing operated elsewhere.
Yes, ma'am, elsewhere. 20 years ago, elsewhere she was operated.
Okay, so in the discussion you didn't talk about the causes mentioned in literature. What are the causes? Why you see recurrence in these patients with dermoid cyst?
Recurrence is usually due to incomplete excision of the cyst, ma'am.
And any other reason?
Incomplete.
If it's a dumbbell dermoid cyst, if it
if
has
it's a deep,
yeah, there is another component either in the orbit, or somewhere else, then and that is not removed, then they can be, recurrence.
Yes.
And the other thing I just want to emphasize here is that dermoid cyst, nowadays we decompress. So don't go by this that we have to take it out in toto and give a, a long, scar. That is not required. So just a small scar, dissect a sufficient amount, a small nick, and you decompress, partially take out the content. And once you do that, you have sufficient surgical space and you can operate and take out the whole cyst. See, the thing is that you have to take out the complete cyst wall in toto. All right? And hardly there is any spillage because it is very superficial thing. So for that, you don't have to give a very long, scar over there. So decompression is something which is mentioned in the literature. So it's not that every time, it's not that you have to take out in toto.
Yes.
We do it routinely. You just give a nick, decompress, have a good surgical space, small cut, minimal manipulation, take out the whole cyst wall, the content, and give wash. And there's hardly any leftover spillage there in the surgical site. You can easily see and wash.
Yes.
All right, so that makes it less invasive and a small scar.
Yes. Thank you, ma'am.
Okay. Thank you, Dr. Anubha. I would now like to invite our next speaker, Dr. Megha, who will be presenting on the myriad presentations of orbital cellulitis.
Good morning, everyone. I'm here to talk on the myriad presentations of orbital cellulitis, and I'm Dr. Megha Sugunan. So, orbital cellulitis commonly presents with proptosis, limitation of ocular motility, eyelid edema, erythema, pain, and chemosis, often with a history of recent upper respiratory tract infection. A clinical diagnosis is possible in most patients. A CT orbit with paranasal sinuses helps to confirm the diagnosis. We report 3 cases of orbital cellulitis which presented with diagnostic dilemmas. Case 1 was a 74-year-old male. He had no non-comorbidities and he presented with redness, lid edema, itching, and minimal pain in the left eye of 1 day duration. He had a history of lower respiratory tract infection with Pseudomonas aeruginosa for the previous 2 weeks, and he was treated with oral antibiotics, and the respiratory infection had subsided. On examination, he had a visual acuity of 618 and 624, which improved to 69 in both eyes. But on ocular motility examination, he had a -1 abduction restriction in the left eye. And the left eye had lid edema, hemorrhagic chemosis, nuclear sclerosis grade 3, and his pupils were brisk. Dilated fundus examination showed no disc edema. Right eye was normal except for a nuclear sclerosis of grade 3 to 4. We made a provisional diagnosis of angioneuritic edema in the left eye. Case 2 was a 21-year-old female with no non-comorbidities, and she presented with redness and watering in the left eye for 5 days, and then right eye for 3 days. Initially, the left eye was treated with topical antibiotic steroid combination eye drops, but 2 days later, she developed lid edema, headache, and pain on eye movement in the left eye, along with redness and watering in the right eye. On examination, her visual acuity was 6.6 in both eyes, with -1 abduction restriction in the left eye. Right eye had conjunctival condition and predominantly in the fornices. In the left eye, there was conjunctival condition and left preauricular tenderness. Pupils were brisk in both eyes and dilated fundus showed no evidence of disc edema. A provisional diagnosis of viral conjunctivitis was made in both eyes. Case 3 was a 41 years old female. She had a past history of hypertension, hypothyroidism and ANCA-associated vasculitis with recurrent episcleritis, and she was on TAP hydroxychloroquine. She presented with chief complaints of redness, lydedema, pain on eye movements in right eye, and right-sided headache of 2 days duration. She was treated elsewhere with oral amoxicillin clavulanate, but there was no symptomatic improvement. On examination, she had visual acuity of 612 in both eyes, which improved to 6.9 with pinhole. On ocular examination, motility examination, she had -2 restriction in all directions of gaze in the right eye. And the right eye also had periorbital edema, diffuse conjunctival condition with 360-degree chemosis, and pupils were brisk. Dilated fundus examination showed tortuous veins with internal limiting membrane folds in macula, and no evidence of disc edema or subretinal fluid in the right eye. Ultrasound B scan showed posterior scleral thickening with local effusion, but there was no T sign. Provisional diagnosis of posterior scleritis was made in the right eye. This is the clinical picture. None of our patients had any diminution of vision or proptosis or raise in upper respiratory tract infection or fever. This is the case 2 and the case 3. But the CT orbit with PNS was ordered and it showed periorbital fat stranding in all the 3 patients, which were suggestive of orbital cellulitis. And the total count, except for the first patient, both the other 2 patients had leukocytosis with predominant neutrophilia. And surprisingly, none of the patients had evidence of any paranasal sinusitis on CT scan or even in diagnostic nasal endoscopy. The treatment in all the 3 patients, initial diagnosis revised to orbital cellulitis following this investigation, and all the 3 patients respond to intravenous antibiotics covering gram-positive, gram-negative, and anaerobic organisms. So a conclusion is that orbital cellulitis is an ophthalmic emergency. It may present with atypical presentations mimic as potentially less severe ocular pathologies. So a CT orbit with paranasal sinuses can help to cleanse the diagnosis of orbital cellulitis in such situations. Thank you.
Thank you, Dr. Megha. You said that none of your patients had proptosis.
No, none of the patients had proptosis, ma'am.
Then how you are calling it orbital cellulitis? Because that is one of the important sign when we, differentiate orbital cellulitis from preseptal. That is the thing we look for.
Yeah, ma'am. That is what, because only but in all these 3 patients, the CT had predominant that fat stranding was present, probably in the periorbital fat inflammation. That is why we made the diagnosis like that. And
So
they
that
had
will be preseptal cellulitis then.
no,
is
it
how
was
we
in the
differentiate.
intracorneal fat stranding was present, ma'am. Intracorneal
So
fat
patient
stranding.
must be having some proptosis.
Yeah, unfortunately, none of the patients had, and
Then you need to revise your diagnosis, I must say.
sorry.
And
ma'am.
posterior scleritis is not orbital cellulitis. In orbital cellulitis, you can get posterior scleritis, but posterior scleritis is something, it's a different entity.
Yeah, we had, the patient had fat stranding and leukocytosis also, so we thought it might not be posterior scleritis, and that is why we reviewed the diagnosis to revised it to orbital cellulitis. And she also responded with these IV antibiotics only, so that's why we retrospectively diagnosed it like posterior or orbital cellulitis.
Okay. Any other question?
How did you make the diagnosis of viral conjunctivitis in a patient who has extraocular movement limitation, which is painful?
Actually,
The
she
provisional
had,
diagnosis
yeah,
itself
yeah, ma'am.
is-
Initially, it was thought like viral conjunctivitis, but because she had symptoms also developing in the other eye with conjunctival condition, watering, redness, and all. That is why we thought, because bilaterally it was unlikely to get orbital cellulitis. So it was initially thought like viral conjunctivitis. Maybe it could have been a complication of adenoviral conjunctivitis to develop the orbital cellulitis in left eye. Probably that way.
It's quite unlikely, but
Yeah.
even the first diagnosis of angioneurotic edema which you made with the restriction of eye movement, that is also questionable.
Have you, in the review of literature, have you found out that apart from the fat stranding, and which was also minimal in your intracorneal
Yeah.
space, what are the other findings of CT or in CT orbit and paranasal sinuses in cases of orbital cellulitis, since there was no proptosis at all?
Yeah, usually
clinically?
there would be some extraocular muscle edema that
Hmm.
that usually would be present, but these patients didn't have any.
So I believe there is a not corroborating completely with the diagnosis of orbital
Yeah,
cellulitis.
yeah. Then also, but in fact, all these patients responded to IV antibiotics also. That is why we were also thinking on the line of orbital cellulitis, ma'am.
Okay.
Thanks.
Thanks. Next, I invite our next speaker, who is Dr. Arka Chatterjee. Dr. Arka will be presenting Cut the Bridge, a case series on ankyloblepharon.
Good morning, everyone. I am Dr. Arka Chatterjee, and I am here to present a case series on ankyloblepharon. I have no financial interest, and I would like to thank my professors. Ankyloblepharon refers to a partial or complete fusion of the eyelid margins. Etiologically, they can be congenital or acquired and may have syndromic associations which present with multisystem involvement. Clinically, they may cause visual obstruction and may be an indicator of underlying systemic conditions. Now, coming to pathophysiology, during normal development, eyelid separation occurs between 12 to 20 weeks of gestation through apoptosis. But any disruption in this epithelial remodeling leads to the failure of the separation, leading to ankyloblepharon. They may have various syndromic associations like Chand syndrome or Havel syndrome, which has been depicted here, and other ectodermal dysplasias. Clinically, they may cause visual axis obstruction, ocular irritation, and cosmetic deformities. They may present with bilateral or unilateral presentations and may have orofacial or limb deformities associated with them. Grossly, they can be divided into congenital or acquired cases. Congenital present at birth and may have syndromic or non-syndromic associations, whereas acquired cases present late in life and may be caused due to trauma, burns, or ocular infections. I will be presenting 4 cases of various etiologies. Here is the first one.
This is a case of ankyloblepharon filiform adnata. Here, the mother of the baby presented the baby to our OPD at 1 month 10 days of her age. The take-home messages in these kind of cases are to operate on this baby as soon as possible to release the epithelial bands and to prevent any kind of stimulation deprivation amblyopia. This case was done under sedation, where the epithelial bands connecting the 2 eyelid margins of both the eyes were crushed with a mosquito forceps, and the bands were released individually from both the upper and the lower eyelid margin very carefully. Hemostasis was maintained and a good post-operative result was achieved.
The second case is that of a lateral congenital ankyloblepharon but late presentation. Here's the pre-operative picture of the patient. We did a surgery where the lateral ankyloblepharon was cut and amniotic membrane graft was placed and sutured. The post-operative pictures showed resolution of the bands. The third one is that of a 60-year-old lady with lateral ankyloblepharon associated with ptosis. These are her pre-operative pictures. A surgery was done where the ankyloblepharon was cut and post-operative relief of symptoms was seen. The fourth and the final one is that of an acquired ankyloblepharon caused due to Stevens-Johnson syndrome. The patient was referred from a dermatology ward and this is his pre-operative picture. Surgically, the procedure was done where the bands were released and forniceal sweeping was done. Immediate pre-operative pictures showed relief of the bands, but the patient was advised to do the same sort of sweeping with ocular ointment, which he did not follow properly, so it led to a similar front formation. Coming to my take-home message, we have learned that ankyloblepharon may have various etiologies, may have various causes of origin, and may have can be associated with various syndromic symptoms. But the clinical picture remains the same in more or less all the cases, and surgical management is required for the relief of the symptoms. Thank you.
Thank you, Dr. Arka. I just wanted to know about your second and third case. Both were quite old. So what was the etiology, congenital?
Yes, sir. We took the history from the second case and the third case as well. They they didn't feel any discomfort because of the ankyloblepharon, but it was present from birth only, but they didn't come to any hospital or OPD for checkup for that. And
Because
so it
maybe
wasn't
it
treated
was
anyway.
because of the laxity of the lateral canthal tendon. That's what I could see, the rounding of the lateral canthals. And did you see the lid margin and the lateral canthals in these patients, or you just slit the thing there?
No, the
Lid margins were present there in that area, because what I could make out was just rounding of the lateral canthus and medial shift of the lateral canthus. So which can happen, in old patients because of the extreme laxity of the lateral canthal tendon. So
um, the um,
because why they will present so late if it was
yes.
present? So that's why I'm wondering about the etiology.
We saw we did
So when
the
you had
workup.
cut that time, you could see the lid margin over there in that area.
Actually, the surgery was done by one of my seniors.
Okay.
But the thorough follow-up, the clinical workup was done preoperatively, and provisionally it was diagnosed as a lateral ankyloblepharon.
All right. Any other question?
That was my question. I was just questioning the indication of the surgery only.
Thank you.
Thank you. Now I invite Dr. Tanya Chakravarti. Is she there? Dr. Tanya will be presenting levator plication versus silicon frontalis sling in severe ptosis with poor levator function.
Good morning, everyone. My topic for today's presentation is levator plication versus silicon frontalis sling in severe ptosis with poor levator function. Ptosis is drooping of the upper eyelid, which can be congenital or acquired. Severe ptosis is usually operated in the following way. Number 1, frontalis sling with fascia lata autologous homogeneous fresh or bank sclera. Frontalis sling with artificial material like silicon rod, Mercedin mesh. And the third one is maximum levator plication or resection. Our study is to evaluate the function and the cosmetic correction, recurrence, complication in both the procedure of levator plication and frontalis sling with silicon rod. It is a prospective comparative interventional case series of 40 eyes, 25 were male and 15 were female. Group A of 20 eyes were operated with levator plication, and group B of 20 eyes was operated with tarsofrontalis sling with silicon rod. We included patients of 5 to 45 years with no sex predilection, patients with congenital ptosis, severe ptosis, poor levator function, neurogenic ptosis, BPS syndrome, and patients with good positive Bell's phenomenon. We excluded patients of vertical squint, negative or poor Bell's phenomenon, Marcus-Gunn jaw winking phenomenon, mild to moderate ptosis, and corneal anesthesia and nystagmus. Out of the 40 cases, Group A undergone levator plication and Group B undergone tarsofrontalis sling with silicon rod. In the result, we can see that comparison between the Group A and Group B result shows that there was a group uplift with brow up and brow normal position in Group B, which is statistically significant. 6 cases of Group A was grossly undercorrected and planned for revision surgery, and in one case of Group B underwent readjustment of the sling due to overcorrection leading to exposure keratopathy. And in one case of Group B, there was sling infection and removal of the sling, and the patient was planned for revision surgery. Now in discussion, we can see that the severe ptosis with poor function of LPS is mostly seen in unilateral cases, and in these cases we did not interfere with the other healthy eyes and tried to maintain the symmetry by adjusting the affected eye's lid height in both the groups. In ptotic eyelid, the LPS muscle is unable to relax, so that there is upper eyelid retraction in down gaze. In the plication, if the procedure is failed, the lid comes back to the previous state of lid height. Never the complete ptosis, which is possible in LPS resection. In sling surgery, if the undercorrection or overcorrection occurs as a complication, then the readjustment of the sling can be done at the apex of the pentagon. In respect to the uplift of the lid post-operatively, between the Group A and Group B, there was a good uplift between the uplift with brow up and brow normal position in Group B, which is statistically significant. So in conclusion, we can see that in severe ptosis with poor function of LPS, the tarsofrontal sling with silicon rod is superior to LPS plication with 1 year follow-up, because postoperatively it is maintaining very good cosmetic lead height with good elastic property during blinking action. As the tarsofrontal sling procedure is a minimally invasive surgery, so the early rehabilitation could be possible, and overall the postoperative complication is also minimal. This procedure does not require too much anatomical dissection, and it is an easy to perform surgical procedure. Thank you.
First of all, I would like to say that your presentation was very crowded. You could have put less points in a slide and made it readable for us. Okay, so font size was small, and you should have depicted it more through charts and pictures. That would have been easy to decipher. Okay, so my question is levator plication usually done in congenital ptosis?
Mainly, ma'am, sling surgery is mainly done. Plication is also done, but mainly sling surgery.
No, so I just wanted to know the rationale of the study.
Okay.
But there are some aims for which you take up a study, so that's my question. What's the rationale of the study?
And both the surgeries are done. More common is sling surgery.
Okay.
More common is sling surgery. Mostly sling surgery is done.
Actually, she rightly said, see the outcome of ptosis depends a lot on the etiology of ptosis. It's because of congenital or acquired, inacquired, what is the etiology, underlying problem, neurogenic and all that. So it was like a mix of thing in your study where you compared two, techniques. And plication mostly is done when there is some LPS action. The indication of both the surgery as such, if you see, indications are different. So like there is some basic problem with the study design also, like when you are comparing two, techniques, at least the etiology, underlying etiology, maybe in the congenital cases or required, some uniformity has to be there. All right, and yes, plication routinely we do in congenital ptosis patients in our setup where the LPS action is, fair to good. Patients coming with mild, moderate, especially moderate, mild we do MMCRs, in congenital I'm talking about. And in moderate, ptosis where there is fair to good LPS action, we do application as a routine procedure. And then silicone sling, we know that it is done in patients with severe ptosis and poor LPS action, and generally not a choice for epineuritic or say, neurogenic maybe, but not for epineuritic. So like it was a bit confusing, study design.
So my question was basically because it's routinely done in mild to moderate cases of ptosis, and you have taken up in severe cases. So there must have been some rationale because of which you took up this study. That's what I was asking. I would now like to call upon, thank you very much. I would now like to call upon the last speaker of today's session, Dr. Abhishek Kumar, who will be presenting on a rare differential of leukocoria medulloepithelioma.
Good morning, everybody. So I would like to present a case on a rare differential of leukocoria. As we all know, there are 10 to 12 differentials of leukocoria. In our case, it happens to be medulloepithelioma. So the history of present illness, the informant was mother, and it seems to be reliable. There was a 2-year-old female child presented with complaint of, the parents presented with complaint of leukocoria in the left eye since 2 months. And it was insidious in onset and progressive in nature. It was not associated with proptosis, trauma to the eye, any exposure to pets, or any deviation of eyes. The birth history, there was no significant any oxygen supplementation. Immunization history was within normal limit, and there was no family history of any other ocular malignancy in the child. So on examination under anesthesia, the visual acuity in the right eye fixation to light was present, and it was done on the OPD basis, and in the left eye, the child was not fixing to light. Right eye was within normal limits, and left eye, the lid and nexa was within normal limits, and there was a circumciliary congestion was present. Anterior chamber was irregularly shallow. The lens, there was a whitish mass with vascularization which was present over it, which is distorting the iris and involving the anterior chamber. So here's the clinical CP. There was a posterior synec, and the nasal, there is distortion of iris with the iris atrophy. And also there was a mass kind of thing which was present posterior to the iris. It was abutting the lens, and there was the pupil was non-reactive, and there was also presence of neovascularization of iris. On fundus examination, the right eye was within normal limit. There was no details visible in the left eye. On the gonioscopy, we found some whitish lesion near the angle, so it could be a anterior chamber seed, or it could be a mass. We didn't know at that point of time. On IOP, the left eye was 38 mm of Hg with bitoxolol 0.5% BD. So we made a provisional diagnosis of intraocular mass with NVG, neovascular glaucoma. On ultrasonography, there was a 6.6 into 4.7 of mass, which was, there was no high amplitude spike suggestive of calcification. So we, in anterior RB, there are also very less chances of calcification, and heterogeneous ovoid anterior mass was there near the ciliary body. On ultrasound biomicroscopy, there was a intratumoral cysts which were present, at which we can see, and it is abutting the lens, causing the distortion of the iris, and there was some displacement of lens also present. So we made a provisional diagnosis of medulloepithelioma, and on MRI there was a T1 hyperintense, T2 hypointense with patchy enhancement. So anterior RB can also be a condition. So we have to just look into mind that there are few differentials of pediatric ciliary body mass, like medulloepithelioma. The age of onset was corresponding with the patient. In melanomas, there are epithelioid spindle cells are present, and there is no patchy enhancement which is present. In anterior RB, calcification may or may not be present. So medulloepithelioma is a rare differential, and it is originated from non-pigmented ciliary epithelium derived from the optic cup, and it is seen in children and rarely in adults. Zimmerman hypothesis suggested the derivation it to be a partially differentiated embryonic ciliary epithelium, and it is more commonly unilateral as in our case, and DICER1 mutation can be associated with few syndromes. Thank you.
What is the most important thing which you have to keep in mind while treating a patient of medulloepithelioma?
Ma'am, in the medulloepithelioma generally presents like this only, like a pediatric ciliary body mass.
It's a typical presentation. What else do you have to think in, keep in mind in treating the patient? Did you work up the patient for any familial associations?
Yeah, we worked up that bronchopulmonary. There was no associated. There is a syndrome associated.
Familial cancers.
Yes, there was no familial. There were no
yes.
familial cancers. Family history was within normal limit and no effect.
And intracranial extension has also to be ruled out properly in these patients. In generally, when you are treating
Yes,
them, that extensive and proper neurological consultation is mandatory for these patients.
Yeah. Thank you.
Did you do the PERB1 gene in this case?
This patient was non-affording in our case, but yes, RB1 gene can be tried in these cases, but there are chances that even if it is RB, then 50% only sensitivity is there. So
how did you manage this case, Abhishek?
So we did a enucleation for this case because the eye was non-seeing. It was neovascular glaucoma with a medulloepithelioma. We didn't know at that point of time, so we did a histopathology. The neuroglial cells were present with a cartilage, so it made out the diagnosis of teratoid variant of medulloepithelioma.
So it conformed with your diagnosis. Thank you. Thank you, Abhishek. So with this, I thank all the presenters for their wonderful presentation. We learned a lot, and there was a variety of cases from oncology, oculoplasty, and many other things. I wholeheartedly thank the chair, Professor Neelam Pushkar ma'am, for her mentoring the session and for enlightening all of us with her vast experience in oculoplasty orbit. And I also thank Dr. Shachi Srivastava for her enlightening thoughts in between the session. So I request all the presenters to please come on the stage for a group photo. And now we officially conclude the session. Thank you. I think a big round of applause for all the presenters. Please come over the stage for the group photograph.